we'll let you do your presentation.
Mm-hmm.
If you want to stop in the middle to ask questions or discuss, that's up to you. And then we'll definitely have some discussion at the end too. Okay.
Okay, yes, because I think it works. Anyway, I would like people, if it's possible, to interrupt me wherever they want.
Absolutely. If I see questions come inside, I will. But if at any point you want to have a bit of discussion about a case, that would be fun too. Whatever you want to do, that would be great.
Okay, that's
Okay.
fine.
Okay.
First of all, thank you very much for this invitation. And TAVI and bicuspid, I think it's still a matter of discussion for interventionalists. And I mean, this is a little bit the summary of what I would like to discuss today. And you will see that in the second part, I will show cases. I mean, we will talk about bicuspid in general, the anatomy, the different classifications, what you can do with surgery, and all the problems with TAVR, and try to understand where we are at this point of experience. Now, the BAV, first of all, it's quite a frequent congenital heart disease. And the prevalence, we will see that it's generally around 2%, but it can change according to the country we are. And in general, it's only the 28% of these patients that refer after 80 years old. You will see that the younger the patients are, the higher the percent of bicuspid is. And anyway, a 10% in general, or all big centers that perform TAVI are bicuspid patients. Now, as I was saying to you before, really the percent of BAV in the world changes. You can see that in Europe, it goes from 6 to 2%, main, I would say 3% in all Europe. In the United States, it's even lower. But if you go in Asia, especially in China, these things completely change. I remember I was proctoring 1 week in China, and I happened to proctor 7 cases, and they were all bicuspid. So if you want to have an experience on bicuspid, you need to go in Asia, and it will be very, very easy to have this experience. The definition of bicuspid is, let me say, a spectrum of deformation of the cusps of the valve, that they can present with 2 functional cusps or even 1. And the mechanism changes the level of the apposition in the commissures. We have many classifications. I mean, I will show 2 or 3 of them. And I would say that the most common one is the Sievert's classifications, because it's able to embrace all different types. As you can see here, we have the comparison between the Sievert's, which is on top, and the one that was made on purpose for TAVI patients. And you can see that there is very little description on the second type, which is the one that has more than 1 Raffi. And here again, there is a summary of, let's see, the 3 main classification, the Sievert's on the top, the BAV consortium, and what I call the TAVI classification, that is the most recently published, where we can also consider the fusion of commissures that are already halfly separated. The most common of these 3 is type 1, and is the most common, especially in the Western countries, that can change the type according to the position of the radi in considering the right, left, and non-coronary cusps. And then finally, the type number 2, which is the fusion of more than 2 cusps. And I would say it's rare, and it's something that is really, really poorly considered when we treat BAV with TAVI. You can see here the anatomical aspects that surgeons know very well. You can see here a photo of type 0 with two main cusps, with absolutely no any way of a beginning of a separation between a second and a third cusp. Here it's the type 1 with a Raffi. And the Raffi is something that if you hear surgeons, they will tell you that it's one of the most hardest fibrotic tissue that you can have. And when they cut a valve to replace a bicuspid valve, this is the one that they cut as the last bit, because it's really, really very strong. So you have to keep in mind, and we will discuss later that you cannot consider that the Raffi opens or breaks with a balloon effect, because this is absolutely quite impossible. This is an example instead of a type 2. You can see two Raffi, one on the left side and one on the right side. The experience with BAV for surgery, it's a good experience. They have a low hospital mortality. The majority of these patients are young patients with a low risk, and they have excellent long-term survival rate. So let's say the increased mortality that we can find is if we go towards the high surgical risk, and this is where, until now, BAV has been considered for TAVI. Now, TAVI has a long story, as you know. We began to consider high surgical risk. Now in Europe, we are still expecting the new guiding lines. In the United States, you have your new guiding lines for valve disease, and so you already have an open mind for low-risk patients. Now, for what concerns bicuspid patients, we are still fixed on a high-risk problem and not a low-risk problem at the moment. This because we still are poor in information and we don't have randomized trial. Anyway, in the market, there's more than one valve that has been, that received the Food and Drug Administration admission and the European conformity to treat BAV, and this is both the balloon expandable and the Medtronic self-expandable. There was before the possibility to use the mechanical spindle, but we know that now it's out of the market. The TAVI has done a few experience, very old experience with the first generations, and a few years ago there were published papers that showed the difference in considering TAVI in the first years than now, but changing the generation. Now with the new generation, we have less pacemakers rate and less paravalvular leak and less gradient. So the treatment with TAVI for bicuspid will probably get higher. And towards the younger patient, we will have to consider BAV with transcatheter access. There's been a recent paper just published a few weeks ago on Circulation, which is a very nice review of the problem. This is one of the figures I picked up with the clinical evidence for bicuspid. You will see that there are much more clinical studies that are taken in consideration in this paper. What is interesting to see that the 30 days mortality, it is quite good. It's around 2.5% for BAV patient with generally the two main valves, so balloon expandable and especially the self-expandable valve. These are the result of the TVT registry for bicuspid with the self-expandable, and you see already that with the evolution of the device, we have quite good results for bicuspid, and we treat bicuspid when we have both stenotic and regurgitation, and you see here that there is generally now no trace or only mild paravalvular leak, and this is very important because that was one of the problems that TAVI had in the olden days with the first generations. The Beaverlook study, it's an experience in Europe made for a discussion around different kinds of sizing that we will see today. And Cheche was considering to sum up all the experience, asking centers to say, you can implant the valve with the annular technique or with the supraannular sizing, as long as that you declare it. And these are the results of this population at 30 days. They were presented last year at PCR. We are expecting the paper with 1 year follow-up in the next few months. And you can see here that the combined sizing or the annular sizing give the same mortality as the previous paper. If we look the sub-analysis of the low-risk valve, which is the Evolute low-risk bicuspid study, which was the one that helped the self-expanding to reach the commercial allowance, you see here that results are very good. I would say there is no dissection, no rupture. These are some main concern that you have for the kind of anatomy of these valves, and the pacemaker rate was quite less, at least, than the first years, where there was percent rate of new PM that was increased more than 20%. Now, instead, we have here an experience of the Washington Center with Waxman showing a very small experience of 61 low-risk patients with a 74% of balloon expandable valves, with a mortality at 30 days, which is proximal to 0. But he describes an experience of 10% of attenuation of leaflets thickening with the CT. These are two things that we could be able to discuss later on at the end of my talk, which, I mean, I left only at the discussion, and these are the thrombotic therapy and the embolic protection, that it's really can be a matter of concern, but it's still open to discussion, and there is no evidence at all for the both. Which are the pitfalls of bicuspid for TAVI? First of all, the anatomy, which you know it's completely different and has sometimes very large dimension, or it seems to have large dimensions, has a high calcium burden. There is the Raffi that sometimes is terribly calcified, and it can be accompanied by the anomalies in the position of the coronary arteries. Sometimes there is mixed disease, there is stenotic, or sometimes can be a high level of regurgitation. And then there is the problem of the atheropathy that is part of the illness of bicuspid. In this interesting paper, I would like to focus your attention on what the authors describe as tapered anatomy and flayed anatomy. Now, if you look at least the drawing, these two drawings here, and you will remind them later on, these are the ones that can explain all the debate that is still on sizing on the bicuspid. The example that the authors give you on the tapered anatomy, they say that, for instance, in this case, you have a wide dimension of the annulus with a 29 evolute or 26 sapien 3 possible for these dimension, and with a perimeter of 83 and a main average of 25.7 of diameter. But when you scroll up in the upper part of the valve, you will see that there is a calcified Raffi, and then if you feel to position the valve in this situation here, the intercommissural diameter, it is a little bit lower. So at the end of these measurements, you could have to decide for perhaps a valve that is a little bit lower in compared to the one of the annulus, which doesn't happen when you find yourself with a flared anatomy, where the measurement at the annulus at 4 millimeters or even higher are absolutely the same, if not even wider. For what concerns the atheropathy, this is something that has been known since many years from surgeons. Sometimes they change the valve, but sometimes they treat also the ascending aorta that can be very much dilated. And what is important, the surgeon after the replacement will follow up the patient in the upcoming years, because the atheropathy of these patients exists and is the one that tells you that sometimes when we treat these patients, we have to be extremely careful, because the tissue of these patients is sometimes a little bit more fragile than normal patients. There have been only 2 studies examining the atheropathy progression after TAVR, and it doesn't anyway seems that there is a progression that is not similar to the tricuspid valves. Now, what we have to gain when we think to treat a patient with TAVI, we have to be careful because the valve can be not completely expanded. We have to avoid paravalvular leak. We have to be careful for an annulus rupture, and the annulus rupture can be due to a higher amount of calcium, heavy Raffi with calcium, and as I was said before, the type of the tissue of the patient. Another thing that generally comes in the technique for BAV is that you easily can find an angulated aortic root with a bicuspid. So we can have to face for risk of dissection of rupture, of the risk of paravalvular leak. We know very little about durability in these valves. Now, if we were face to face, I would have told you and asked you to raise your hand in how many would consider a different kind of sizing in bicuspid. So, but anyway, we can sort of discuss this now, and then I accept any questions about this, if you agree or if you disagree. But this is the scheme that we generally think about the aortic root when we talk about TAVI. We know we've got a virtual ring. We know we've got an anatomical ventricular junction separation, which is more a surgical ring than an interventional ring. and a sinotubular junction, which can be very important depending on the height and on the shape of the valve, but this is any kind of TAVI. So if you consider sizing, we have many kind of sizing now apparently. And these sizing can be done as you usually do with TAVI, considering the annulus measurement. Then there are what are called intercommissural sizing, balloon sizing, or other method. If you remember the presentation of Didier on Bivalux, well, these he considered the annulus sizing and the superannulus sizing. I would say that except the annulus measurement, all the other sizing are a mixture or a full consideration of something that happens on the millimeters up in the upper part in respect to the annulus, that remember the tapered shape that we saw before on that publication. Additional consideration that we need to do when we size a bicuspid are the calcium burden and its impact on the prosthesis. And we said that these valves can be very heavily calcified. The location or the existence and the length of the Raffi, and how much is the root. If the root it is small, if the sinuses of Valsalva are wide or not. And this because if they are small and there is a lot of calcium and there is the Raffi, we have to understand even here if the valve is well accepted, and of course as another TAVI patient, how the coronary ostia will we allow the position of the prosthesis inside. Now, what is the intercommissural distance? Well, the authors that have thought about this, they consider the level of the annulus that you can see here in step 1. They consider the annulus measurement as you usually do, and then they scrolled up and they arrived around 4-6 millimeters, and they saw that a bicuspid, either a type 0 or a type 1, has a diameter, which is the only one that separates either the two fused cusp or the only cusp in respect to the other. And they decided that that measurement was the one to take in consideration that could determine a difference in respect to the diameters of the annulus plane. Another hypothesis was to consider the enlargement or the restriction due to always to the superannular measurement at the level of the intercommissural diameter, done with the help of a balloon. This is a small paper written by a group in China. And you know that in China there are a lot of bicuspid, and they decided that the easiest thing was to do a balloon valvuloplasty with a small balloon. And if the authors did not reach an imaging of the reduction of diameter done by the valve, then they would increase the balloon, arriving to have this situation. So a balloon that was sized as the upper annulus valve with no leak at all, and that would have been the correct size to choose for the valve. But this is a little bit, let's say, sometimes it can be risky, because if you go towards the other step, then you can increase the too much the balloon. Second, it is long. It's a little bit even a subject sizing. To look the intercommissural or whatever happens on the top of the annulus, the technique, which is the CT scroll technique, it is this that you can see here. You go up until you see the changes of the valve. You have the intercommissural diameter. You see if there is or if there is not a Raffi, and you arrive to the annulus. And then you can do your measure to the annulus, and then again you can look the other measures that you want to take in account. And this is done always stopping the scroll around 4 or 5 millimeters. This is what all people that have been struggling with this have decided. The Harvard Multicentral Registry said exactly this. They decided that 4 millimeters was the right way to do, and they confirmed what I was saying to you before about the sizing in upper annular place, where the shape can be tapered, can be flare, can be tubular. This means that in any part you do your dimension, you will have the same dimension of the annulus, and all these things depend on what is the difference according to the different kinds of valve that you are considering at that moment. We always have to remember that the bicuspid valves can change. You see how many kind of morphology we have. There's been a discussion on this, of course, for many years. We still are discussing about it. There are people that say that the annular siding is a standardized, that you can perform a BAV-like measurement, the valve as you usually measure a normal valve, a tricuspid valve, because some authors say that the supraannular measurement, any way they've done, they are not consistent and they are not reproducible. These authors have, with this publication, they compared the annulus with the supraannular sizing, and they looked when they were similar, when they were smaller, when they were larger. And another thing they've done, which can be interesting, is that they look if an inter-observer comparison would change the measurement. And they saw that the annular area measurements were absolutely superimposable, not the supraannular measurements. Now, this can be explained because the measurement of the intercommissural diameter can be reached and can be confused, because you can change from 4 to 5 millimeters and you can find difference in measurement. So in some way, my opinion is, in part, I agree, because you saw with the scrolling registration that the intercommissular diameter can be taken in different position. So what is the best? The other authors, this is the group from San Raffaele of Milan and other doctors, Latif knows them very well. They talked about the LIDA method, which you will see it is something a little bit different, something that in part was already done, and it's, I consider it a bridge between the supraannular intercommissural measurement and what the group here in Pisa has done. What the LIDA method does, it is always a supraannular measurement. They consider 3 levels of plane. They tell you this is the virtual basal ring, which is the usual one. This is the intercommissular diameters, and when there is the Raffi, they are able to look the Raffi position, and at the plane of the Raffi, they consider to do and sign a perimeter of the valve in systole, and then they say that from this perimeter you can choose your valve. The group, like many other groups, would prefer a self-expanding valve in compared to a balloon expandable valve, especially if the valve it's highly calcified. Now, allow me to tell you my point of view is that this measurement is interesting, but you need to be very skilled. The group of San Raffaele has a lot of experience in TAVI, and it is easy. I mean, it's easy if you have a nice CT to look the perimeter in this position. But in high volume centers, sometimes you have to deal with CTs that are not very easy to read. They are not in systole. And so I wonder sometimes who tells me that that is the moment with the correct perimeter to measure. So we try to think, to give an answer, and to be able to say to an interventional cardiology, you would choose, let's say you never do 26 instead of a 29, or you need to choose a 34, exactly as you do when you perform an annulus measurement. So we wanted to reach a number. And we looked the characteristics of the valve. So what we done, we divided the calcification in 3 degrees, levels of degrees, class 1, class 2, and class 3, finding that there was a cutoff. I'm not going to tell you the details of the calcification division, but we arrived to evaluate 2 different groups according to the level of calcification on the valve, and we looked the expansion index of the valves with the CT post TAVI, and then we looked the shortening of the Raffi when these were all valves type 1 according to the amount of calcification in the Raffi. So looking this, we could feel that first of all there is a separation between patients that have mild calcification with high calcified valves, that the expansion index changes according to the calcification, and the Raffi can shorten itself according to the expansion on the valve, but not when this Raffi is highly calcified. Another important thing is we checked if the intercommissural length or diameters was easily to measure. So we did correlation between interoperators, and you can see here that we were able to have a high correlation with the area. We could have a high correlation with the main diameter of the sinus of Valsalva, and we had a high correlation in measuring the length of the Raffi, but we didn't find enough correlation when different operators were measuring the intercommissural diameter, and this was the observation I was talking to you before. So what we observed was that if you look at the Raffi can be long and can be short and can be not calcified or calcified. You will always have a little bit of Raffi left, according also to its length and to the amount of calcification. Now look, for instance, this patient here with a Raffi and with a Raffi with calcification. Well, this part of the Raffi will never be able to get more shortened. And when you will have the valve in position, this difference, which is more than half of the length of the Raffi, will stay there and will never change and will not allow to a bigger valve to get inside. So we decided to do an algorithm to considering the calcium score according to the amount of calcium that was divided in, as I told you, according to the millimeters cube of calcium, calculated with the angio-CT and not with the agathorn. Then we considered the length of the Raffi, and we decided that the Raffi was going to be important if its length was even higher than the 50% of the diameter at the annulus plane. So when you consider a derived diameter, you look the dimensions of the Raffi and you decide if the dimensions of the Raffi are bigger or smaller than the 50% of the diameter. And third passage, if the Raffi is calcific. According to this, we could give the measurement of the valve. In this way, I took a couple of cases. Now look, this patient, we have a type 0. Now you would say, well, with type 0 there's no Raffi, so what should I measure? Well, for us it's the same thing. Now look, the annulus plane, we have an annulus dimension with diameters of 22 and a minimum and a maximum diameters. We have some calcium. It's around, we can calculate the amount of calcium. For this patient, the calcium evaluation was these millicubes. So you can say that has an importance for calcium. So we will decide to subtract 1 millimeters because the calcium would not allow the complete expansion if it's too large. And we subtract 1 millimeters from the average diameter of 22.4. That was the average diameter at the level of the annulus. So we will reach 21.4. But the Raffi, there's no Raffi there, so there is no any millimeters that we would like to subtract to that. So if we played with a valve for a 22.4, we would put an evolute, let's say 26. For this kind of algorithm, only with a calcium burden, we would always keep an evolute valve 26. So you can see here the implantation of the valve. Here there is the pre-dilatation with an undersized balloon here. And you can see a post-dilatation because you can see that the valve, it's a little bit entrapped. It is high, but a little bit entrapped from the calcium. You see here the final after the post-dilatation, no leak, a high valve, no high position, no PM in the future. So you would say I would have put anyway a 26, but this is a type 0. You can have other considerations. Let's, for instance, talk about a type 1. This is, sorry, the echo of the same patient. before discharge. You can see here that there is no leak, and important because it's something that you need to observe. The main gradient is only 5 millimeters. Let's go now to a patient with a type 1. Now, this patient has an area of 734, a perimeter of 96.9, and an average diameter of 30.731. Well, if you look the IFU and you want to put a valve, let's say a self-expandable, we use the self-expandable valve for the bicuspid, as I told you before. Well, it is out of the IFU. What we have done, we scrolled up to look the Raffi, and we saw, first of all, that there is a long Raffi. It is higher than 15 millimeters, is 18. So it's more than the 50% of the average diameter, and it's calcified. It is heavily calcified. So what is the algorithm? What does the algorithm tell us? Now we have an average diameter of 30.7. We have a calcium evaluation of 1,264 cube millimeters. So we have calcium, let's say more than moderate. We detract 1 millimeter for the calcium, and we arrive to 29.7. But we have a Raffi length, which is nearly 18, which is more than the 50% of the average diameter at the annulus level. So we detract another millimeter more. And as it is calcified, this Raffi has even more importance. So we detract another 0.5 millimeters to arrive to 28.2. And so we can actually put an evolute 34 with no doubt. It sounds difficult probably at the beginning, but it's quite easy because the only measurement that you need to do are the usual measurements that you do at the annulus level. The only difference is that you have to look for the Raffi length, if the Raffi, of course, it's there, and we have a type 1. So let's see this patient. This patient had an horizontal aorta, as you see here. We are positioning the valve, and then we decided to have a postdilatation with a 28. Remember that the diameter of the annulus was 30. Now let's see if we can see the expansion, complete expansion of the valve. This is the final result, and this is the echo with a very little leak in only one side. So this patient that didn't have the opportunity to have a valve for the IFU measurement, anyway, we would say a 34 with no doubt. This kind of algorithm can help you, especially if you have borderlines measurement, because are the ones that will tell you if you have to undersize or if you don't have to undersize. Undersize for bicuspid valve, it is not a rule, but sometimes you need to undersize, sometimes you do not. You can see here that before postdilatation, there was a big regurgitation, a big paravalvular leak, and after postdilatation, the difference and the diastolic pressure was fine. So I would like just to spend another 5 minutes for the procedural consideration after you've been sizing your valve, which is what you have to do. Now the pre-dilatation is something that you should do first of all, undersizing the balloon. This is an example of a type 0 placed, and the place of the pigtail has to be in the lowest part. It is very difficult with type 0 to decide the non-coronary cusp, but if you go in RAO, then you can find that the pigtail needs to land in the lowest part of the valve. And the bicuspid predilatation needs to be very, very, very reduced, and you tend to use the minimum axis or sometimes less than a minimum axis. We always tend to predilate with an 18, with a 20, not more than that, because we really don't like to affect the anatomy of the valve. For the predilatation, it is really useful to prepare sometimes the patient, and sometimes to consider the protection if the valve is terribly calcified with some embolic protection. Another important aspect is that you need to postdilate sometimes and to look the expansion on the valve in both sides. This is the same patient. You have here an LAO and here you have an RAO, and this is exactly the projection where the Raffi is. And so here you would find not complete expansion of the valve. So you need to look both, even if you don't have paravalvular leak, to decide for a postdilatation. And when you do the postdilatation, then even here, it is important to remember to evaluate the original anatomical diameter of the patient, not the range of the valve. It is important that you fix to a small diameter, because what you really have to do it is to accompany the valve to expand, not to force the expansion of these valves, because I always said, remember that these valves can be terribly calcified and they can be a risk. So we can conclude, I think I can conclude the talk saying that the risk and benefit of surgery and of TAVI should be first of all explained to the patients. The patient need to know what they need to know and what is the anatomy, the difference of anatomy. You need to decide if the patient is young, what is going to be the lifespan to understand what is going to happen in other 10 years. So it's very important, and it is important to have a further access in coronary arteries. And I would say that it's important that we need some randomized trial, because still now bicuspid are not really completely considered for patients for TAVI, especially if they are terribly young. Now I am here for any question from you.
Hi, Sonia. Thank you so much. That was really a fantastic presentation, because I think it's one of the first times I've heard someone go through all the different ways of sizing in detail, and then, in the end, leave us with an approach where there's, I think, probably the Casper approach, makes a lot of sense and is easy to follow and probably the most reproducible. I must admit, I don't have as standardized an approach myself, but looking at what you do, a lot of the things I do the same, kind of almost mentally, without using the algorithm. So having an algorithm, I think, makes it much more teachable and useful for those learning. So we like to make sure that the fellows get to ask you questions and resolve some of their own confusions about the topic. So I've asked some of our fellows to join, current as well as previous fellows. So we have Dr. Broha, who's our structural fellow, Dr. Manaf, a future fellow, Dr. Demir Ozan, who is a past fellow. And I'm going to pass it on to them for a little bit to ask their questions, and then maybe I'll come back with a few more questions on my own. Go ahead, guys and gals.
Dr. Petronio. I really enjoyed that talk, and I found the Casper approach really enlightening as well. So thank you for sharing that. I have a little bit of a sort of a big picture question, given that these patients, bicuspid patients, are relatively younger when they're getting their valves. Just wanted to hear some of the considerations that you might take in maybe choosing a valve, a balloon expandable or self-expanding valve in light of the fact that these patients may require future re-intervention on their aortic valve, and how that sways your decision one way or the other in terms of valve choice, but other technical considerations with that specific sort of possibility in your mind.
Well, this is a big question because I would say in my experience, I generally considered to be more comfortable, really to avoid even if there are very, very little problems about, annulus rupture and all these things. But I tend to use self-expanding valve. And I used to use mechanical valves before. The question of having to deal with younger patients and to the fact that we will have to try to guarantee the access to the patient for coronary artery disease in the future would make probably a balloon expandable valve in some way more comfortable. But, balloon expandable, especially if you have highly calcified valve with this big Raffi that just doesn't move, can give you a matter of concern in these patients. In the other side, self-expanding, like the self-expanding Medtronic valve, would give you some concern probably later for the access of the coronary artery. But now, in the last years, this thing is getting much easier. Why this? Because probably you know that there is a technique that's been published, and that now all the operators that are using the Evolut system would do is the cusp alignment. And in some way, the cusp alignment helps you to look and to get and to avoid the commissural of the new commissural to get just in front of the coronary ostia. So this, in my point of view, gives more space to the self-expanding valve.
Oh, it's great to see you.
Thank
you for joining. Go ahead, Azan.
Hi, brilliant presentation. Thank you very much. I wanted to ask about with bicuspid valves, there's increased calcium, and we're dealing with potentially younger patients. What your opinions are of the stroke risk in this population, and how we can decrease that risk, for example, with serial protection, and what your practice is and where the data currently lies within that.
Now, for what concerns the risk are probably cerebral protection is one of the most discussed one, because, I mean, I don't know your center with Azim, but we honestly don't protect all patients. I have to admit that. We consider protection, and we do that only when we have a high burden of calcium or a very strange calcium or plaque distribution in the arch or in the ascending aorta. I was, in my experience with the Sentinel system, I was we say in Italian, I was burned by the experience, because I had a patient where there was a complex plaque on the arch, and I said, no, I'm going to protect the lady. And I put the Sentinel in, and I deployed the valve, and after 2 seconds, she had a terrible ictus, a stroke, and it was a posterior stroke because the posterior vertebral was not covered. Okay, so, and Sentinel, it's one of the easiest way to protect. We now are using even, the new version of the tree guard. We use when we have an arch which is highly complex, but the problem is that even then sometimes we struggle with the valve. We have to push to pull and all these strange things. So I think it's a matter of debate. We have published a paper a couple of years ago on the protection of the stroke and looking the MRI not only after, but after 2 months. And we saw that all positive ischemic, white little things in the subclinical patient with a proven at least 1 or 2 subclinical positive things were disappeared after 2 months, most of them. So, we are not able to decide to do the protection to all the patients. Honestly, we don't do them. I admit, probably in the future, I would say I was wrong. We don't have numbers of stroke. I don't know what is your experience, but I act in the same way when I do bicuspid.
Yeah, I mean, I must admit, here in New York, we're protecting probably most patients, probably about 80% of patients we protect. The truly low risk patients we don't, because I think the risk, if you look at the low risk studies, was so low that it's hard to justify it. But it's amazing, when I first got here, Sonia, and working in Italy, we were limited by being able to use protection devices by money, obviously.
Yes,
right? Financially, right. Even if we like to do it, financially it's difficult. Let's face it.
Yes.
Yep.
It's like that.
Yep. And when I started working here, it was interesting. I got, besides the fact that I believe in cerebral protection, I got pressure from a couple of different things. I got pressure from referring physicians who said to me, quite honestly, when I send my patient to Colombia, they get cerebral protection all the time. So how come your hospital doesn't do it? But what convinced me the most was when you sit in the clinic and you talk to patients about risks and complications of the procedure. Most patients, when you mention the risk of stroke, and usually I quote a risk of stroke of about 1 to 1.5% of stroke. That's my stroke rate, about 1.5%. They still cringe at the thought of 1.5%. And patients started asking, but doctor, isn't there anything you could do to potentially decrease my risk? And so we started using it more liberally. And now we're at a point where we're kind of using it almost in 80%. I was looking today, we got 4 TAVIs today, and they'll all get cerebral protection. They're all above 80. One's had a previous stroke. They have peripheral vascular disease. So we've been using a lot more of it. But I agree with you. If you had to look at the clinical data to support the use, even in tricuspid, it is limited. I mean, that's why, some of you may know there's a huge study underway called Protect TAVI, where they're enrolling a large number of patients and they're randomizing them to protection versus no protection with a clinical endpoint. I think finally that study will resolve it.
I think, yes, that we need a study to resolve that, and we need probably some predictors. I mean, if we had really, true predictors, that would make things easy, even for us that we have always to deal with money, as you said.
Yeah, absolutely. Sharon, did you have a question before I move on to the panel's questions, to the participants' questions?
Yes. Thank you for the interesting talk. My question was, you showed the data about leaflet thrombosis, and I was wondering if you would change your anti-thrombotic regimen post-TAVR compared to the usual anti-thrombotic therapy.
Well, the problem of antithrombotic therapy in TAVR in general, it's changing. And it's been changed for the recent randomized trial. And it's very strange because it changes and it goes in the opposite ways. Because we used to do double antiplatelet therapy because we used to mimic coronary artery disease. And now there is popular that tell us that you can do aspirin and that's it, or you can do anticoagulation and that's it. I think that it will be easier in younger patients, I mean in low-risk younger patients, to decide. For instance, if we find like valve-in-valve or bicuspid with bulky anatomies, to put them in anticoagulation, because the problem of anticoagulation deals with old people. When you have old people, that's the problem. And this is why, if you think, in all these years, surgeons have changed and reduced the anticoagulation and shift from mechanical valves to biological valves because they wanted to avoid anticoagulation. So, I mean, I think we will have to separate, different kind of patients, probably even different kind of treatments to decide how to treat them. Of course, I mean, a simple TAVR can go with aspirin per se if there's a low risk patient, but there are some situations where probably I would be more comfortable in putting an anticoagulation. By the way, there are some valves that seem to make thrombosis a little bit in a higher percent. And I have to admit that a couple of patients that we found with CT, we found a gradient with the echo and then thickness of leaflets with a CT. We have put them under anticoagulation with Coumadin, and they were perfect after 2 or 3 months. So, I mean, it's a thing that we have to deal with.
Absolutely. Mark, I saw you raised your hand, so if you want to ask your question, otherwise I'll ask it for you. In the interim, Sonia, there was a question about valve positioning, okay, and valve height. There's when you speak to people out there, particularly those of our colleagues who are teaching and proctoring in China, they talk a lot about not just supraannular sizing, but also almost supraannular positioning for the valve. So there's a couple of questions here, I think, because people are confused, even I'm confused, about what do you do about height and where do you position in a bicuspid? Do you do it differently? Because there's also the thing that you mentioned, often there's under expansion, so you may need to post-dilate, right? And we know these valves foreshorten. So just, any thoughts about height and height of implantation?
Well, we've begun to consider the height of implantation when we decided that the valve is tapered higher than the annular size. So, and sometimes you notice that the valve slips down because it has constriction in the upper far side. I find that it's more easy when you have the correct size of the valve. So you don't force a bigger valve, because then, of course, the constriction is even higher. You tend to use a higher position, but let's say, I think that the question of getting supraannular, it is too much, because not only a question of the supraannular plane, but it's a question of the coronary arteries. If we tend to put these valves so high in the future, how will we be able to do a TAVR in TAVR with these patients? So I think that we will have to deal with to compromise the two questions and not to gain to incredible heights on these patients. This is what I'm thinking in the last few years.
Yeah, well, I think you're right. I think when we were implanting in patients who were 85 years old, you know, who were going to get one valve for their life, it was the discussion, the thinking was different. Now that we're implanting in younger patients, we need to think differently. There are a couple of questions on the chat, Sonia, about, I guess I would summarize it as to, you know, we know that often it's the Raffi, that's calcium, that's an issue. Is there a place for like leaflet modification? You know, whether it's something like leaflex or picardia that cuts the leaflets, or shockwave or silica to cut it. What do you think?
Well, let's say, I think that the technique of basilica, it's quite complex, okay? And second, you think that you succeed with basilica when you cut the cusp in the middle. At this point, you have in the middle the Raffi. So anyway, when you cut that big cusp there with the Raffi, if there is the Raffi, the thing becomes a little bit more complex because you have a big cusp one side and a little bit to the other side. So I don't know if this would help more than usual. In some way, it is more interesting, the shockwave concept, because this, I think, will have a future in valves. That is a future that I can feel it is not so away from us.
Excellent. So maybe one last question, Sonia, and I'm going to let you go. I'm sorry, there have been so many questions.
No, it's okay.
So maybe just to maybe understand your practice, and I'll share mine afterwards as well. You know, with the low risk studies that have occurred now, okay, just to understand how it's impacted your practice, particularly because, you know, as we start treating younger patients and low risk patients, we are going to find more bicuspids. So, you know, are you finding that you're treating younger bicuspids, or are you still reluctant, and are you waiting for a randomized clinical control trial?
Now, the position of Europe, it is a little bit more different now, because you have your new guiding lines, and we are waiting, expecting the new guiding lines in September this year. I hope that they generally are similar anyway. They're not so different. So, but I feel that if I think of a patient that it's younger than 74, let's say, well, I would have a little bit of concern, because still I need to understand what will happen to a patient of 70 years old at 80. He will have to have a TAVI. And the experience that we have for TAVI now are small. You have done TAVI, I'm sure. I have done TAVI, and sometimes we have a little bit of a problem, because now we see valves that are old. They are the first or second generation. We don't see the valves that are now, but probably even the TAVI valve will have to change, like surgical valves are changing now. Now surgical valves are done on purpose to have a valve in valve. And I feel that industry companies now will have to face this problem. Because, so, I mean, just to come back to your question, if the patient is too young, well, I still have a matter of concern.
Okay, yeah, I agree. I mean, I think we shouldn't completely generalize the data we have on tricuspids to bicuspids. I mean, we have an active heart team discussion about it every time. But, you know, in a 70-year-old bicuspid who's got no aortopathy, who has, it's not super calcified, so we'll get good expansion and good sealing. We, in our practice, will now, with the guidelines, consider a TAVI in a bicuspid. if we can also, maintain coronary access. So we already started to have that discussion with patients and look at it. So if we can put in a large balloon expandable valve as our first valve, we'll then consider it. Otherwise, we probably won't, because we're concerned as well about what will happen when that patient needs their TAVI and TAVI. But it's difficult discussions, and I think, the adjustment I feel I'm making, but not everybody's making, is to think about the lifelong management of a patient, and not just getting through having success at the first procedure, but what will the second procedure look like?
Yes, things change with time.
Sonia, that was really phenomenal. Thank you so much.
Thanks to you.
You.
Very nice to see you.
Yeah, you too. Okay.
Ciao.
Ciao.